Hello and welcome to this episode of Dokkcast number 6, where we cover the subject of menopause. My guest today is Dr. Laura Wood, who is a specialist private GP working at Muse Medical with a laser-sharp focus on menopause, its treatment, and all associated symptoms. Welcome everyone to our Dokkcast podcast today, and I'm delighted to have Dr. Laura with me today from Muse Medical GP practice in central London. Tell us a little bit about yourself, Laura.
Hi, so I'm Laura Wood. I'm a GP and I work as a private GP now and have done for many years. Before training as a GP, I trained in obstetrics and gynecology, so I've always loved women's health. And going forward now, that's translated into doing a lot of work around menopause. So
Amazing.
I have followed most of my patients for many years, and we have all gone through life stages together, and now we're all sitting in perimenopause together, or menopause. So that's
a very, very, yeah, and it's a very, if I say life topic, you know, people really want to be empowered and understand their bodies and what it is that they could do and what it is that they should do and what their body means if it's doing one thing or another. So we're going to cover that and how that relates to menopause. Let's begin at the beginning. If we try to define what menopause is, because I think people think they know, and certainly will have different understandings of symptoms, could you define it for us? Yeah. What would you understand by that?
So important thing. So there's perimenopause and there's menopause, and those two words get used really interchangeably. And I tend to use menopause to refer to the whole lot of it because it's too complicated. But menopause is the day of your last period. Now, we don't know that's the day of our last ever period until a year has passed and we've been a year without those periods. So once we've got to that point, we are then post-menopause. We are post-menopause then for the rest of our lives. Perimenopause is all the hormonal changes that lead up to that last period.
To that point.
And we will get different symptoms in perimenopause and postmenopause, but there's a lot of overlap, a lot of the same. And those, in that build up to our last period, our periods start to change and kind of anything goes. The important thing to know is that time frame can be anywhere from sort of 4 to 10 years or sometimes even longer. So often women are experiencing perimenopause symptoms as early as their late 30s because the average age for menopause in this country is 51, but it's earlier for some women. So a lot of people in their mid-30s, things start feeling not quite right and they think they don't know what's going on. And a lot of doctors will tell them, well, it can't be menopause, you're too young.
Because you're 35, yes.
But it can be. Those early changes start. So all those hormonal fluctuations lead to our periods becoming shorter, longer, heavier, lighter, longer in between, shorter in between, anything. So we can't, anything does
that
go
makes
to
it really
extent.
difficult to not just diagnose, but for you, the person experiencing those symptoms, to understand where you are in this life spectrum, life event, life cycle. Let's take it even back a notch. So obviously menopause being that very last day of your very last period, then you don't really know when that last day is. Kind of reminds me of when we say that you never know when is the last time you've ever picked up your child.
Yeah. Oh gosh, that always makes me so sad.
I know, doesn't it? Slight, oof, dagger to the heart, that one. But so it's almost a retrospective, a look
It's totally
back.
look back. Yep.
Yeah, that's it. And I now have not had a period for a year. Help us understand how that maps or what that means in terms of the menstrual cycle and where periods sit in that. So people can understand what is happening to your body and why, therefore, the menopause symptoms can be so highly varied.
Yeah. So what's happening is we are born with a certain number of eggs. And when we start our periods in our teens, we're releasing an egg each month, and that's when we ovulate. And that egg is what can then be fertilized, and we can then become pregnant. We have only a finite supply of eggs. And when we've had our
run through our
last egg, then we won't have any more periods. In our sort of whenever perimenopause starts, mid-30s, early 40s, we may not be releasing an egg every month. And that, what we call that ovulation. If we're not ovulating every single month, we don't then get that very regular period that we're used to. So that's when we start to see the periods changing in terms of being less predictable. The thing to say is that those changes to your periods often start after some of these other hormonal things have taken place. So a lot of women will also think that they can't be in perimenopause because they're still getting a regular period, and that's so that's confusing as well. So we've lost that change of that predictable monthly bleed, and it's the most important thing is that even if that is still really regular, it doesn't mean that what you're experiencing can't be around those
menopause. And so perhaps just at a relatively high level, touch on the hormonal changes that happen with a normal menstrual cycle. What happens in the half before you ovulate? Because of course you've got your period, which lasts for a certain amount of time. Then you get a new cycle. Then what happens between that and ovulation, and from ovulation to the next period?
So if we don't conceive, so if we don't get pregnant around the time of ovulation when that egg's released, our progesterone levels fall, so that we can, and that's then when we have a period because the lining of
the womb sheds
with that drop. And during the rest, then after the period, then our estrogen levels are picking up again, and we are, that womb lining gets thicker again, so that there's a nice lining there for any potential baby to be implanted into. What's happening in perimenopause, the main thing that's giving us symptoms is our estrogen levels are changing. That's what most people those symptoms the symptoms those people are experiencing most
are related to the estrogen.
But it's not just lack of estrogen, it's the fluctuation. So we will, and it's very unpredictable as to what's going on. One day, if we tested a estrogen level, it could be totally different to another day. So that's why it's very difficult, again, for a lot of people to be able to pick out what's what, because they could go and have a blood test and see their estrogen levels. Oh, that's normal. We see there's a hormone called follicle stimulating hormone, which is what's helping our
FSH,
exactly,
follicle stimulating hormone.
And that goes up as we enter perimenopause and menopause. But again, that fluctuates wildly. So one day could be one value and one day could be something totally different. So again, not very helpful in diagnosing. So a lot of women think they should go and have a blood test and see if they're in perimenopause. It's not very helpful.
Okay, that was going to be my question to that.
The exception to that is when women are, younger and we're thinking about premature menopause, or then we may want to know that that's what's going on rather than something else that's causing their symptoms. So we would test in younger women, but you do at least 2 readings. You ideally do one and you do another one 6 weeks later, or 4 to 6 weeks later, and see if that's consistent before saying,
that's definitely it. Okay. So that was going to be my next question, because very often people want to understand their bodies will go, I would like a blood test for that. So are we saying that blood tests that contain or measure estrogen and FSH, follicle stimulating hormone, are not always the best measurements, and although they support the picture, they're not diagnostic in and of themselves?
That's okay. I wouldn't, for my average lady in her kind of mid-40s coming to see me with various symptoms, which we'll come on to talk about what those might be, I would be going far more on her symptoms than I would what a blood test
Would you do a blood test anyway?
So what I would test for is to make sure we're not missing other things that can mimic those symptoms. So early perimenopause symptoms, a lot of women are struggling with anxiety, they're struggling with their energy levels, they're struggling with mood changes. So it's really important to rule out other causes of that. The other thing that people don't realise is that at the time around perimenopause, we're much more likely to experience issues with our thyroid. So it's making sure we test our thyroids and making sure that actually your thyroid isn't overactive or underactive, and actually that's what's causing some of these symptoms. Two might be going along at the same time. But we don't want to not treat something.
And of course, thyroid symptoms of differences in energy levels, activity levels, engagement, fatigue,
period changes,
hugely overlap.
Yeah, exactly. Yeah. So some people won't have a period because their thyroid isn't working properly.
Yeah.
And you're like, oh, hang on, that's what's going on. And I can think of at least a couple of patients of mine recently who that has been the case for. So you want to check those things. I want to check things like their iron levels, their vitamin D levels. Are there other things we could be correcting which might not be helping the whole picture?
So let's pick that up and say, I know it's very difficult because of course it's a very varied course of presentations. What would, if there is such a thing, a typical woman presenting to you where you think, or they perhaps are suggesting, I think I'm perimenopausal or menopausal, what are the symptoms and the complaints they'll be presenting to you with, and what tests, you've touched on some of them, would you be doing to investigate?
Yeah, so I would say 95% of this comes from what the woman's telling me, what their history has been. The commonest things, and I think the things that people don't necessarily attribute. So people say, if I went out into the street and asked 100 women what they thought most common symptoms of menopause were, they would tell me my period stopping and getting hot flushes.
Correct.
They happen quite late in this whole sequence of events. And the things that women come to me most commonly with are anxiety, low mood, difficulty sleeping, and they put them all down often to other things. So they'll often go, well, I'm really anxious, but actually my son's doing his GCSEs, and actually my mum's just been in hospital, and I think it's all of this, and I'm not sleeping because I'm stressed, and because I'm stressed, and so it's all.
And to be fair, a lot of life events are happening around that time.
We're now in that sandwich
generation. Yeah.
So we've got kids who are getting bigger with bigger problems, and we've got aging parents
who are living longer.
With
more illnesses to some degree that we're better at treating and managing. So they will hopefully, live longer with those, unfortunately, to some degree, in the sense that they then have to have that disease burden looked after.
And that's all. And our kids are, at that time, life is getting a bit more important, and they're just giving us more things to worry about.
Yeah.
So, and we're stuck with all these hormonal changes going on, going, oh my God.
And do they sort of come to you and say, help me understand what's going on? Or do they actually come to you and say, I think I'm menopausal or perimenopausal? How does that conversation go? And importantly, to your point, what do you test them for to ensure that you've looked at the whole human, of course, not just...
It's an interesting mix. I see some women now, because a lot more women are a lot more informed. There's a lot people are talking about it a lot more. My generation, my mum was not telling me about her menopause, I can tell you, and none of her friends are talking about it.
Some of the symptoms are quite personal.
Pretended wasn't happening, so we swept it under the carpet because it's natural.
Yes.
And just because it's natural doesn't mean it's good.
Yeah.
And so some women are coming saying, "Is this?" But other women are coming in primarily to see me because they're really anxious.
Yeah,
and
they don't feel well.
They're really low. They don't feel right. They don't feel like themselves. They're not recognising themselves. They gained a whole load of weight. Like nothing's changed in what they're doing, but they've suddenly put on a load of weight around their middle. So they're like,
what is going on?
What is going on? So it's a bit of, okay, well, let's do a lot of those tests. So I'll run a sort of full profile on women. So I'll check, as I've said, their iron levels, their vitamin D, we'll check their thyroid function. We're checking things like their cholesterol and their blood sugar, because how we handle how our blood sugar is managed and how our cholesterol is managed as we go into perimenopause and menopause really changes. So want to know where we're at with all of those.
So you want to know cause and effect, don't you?
I want her to track what's going on. If there's a big question mark, I may run some of those hormone tests.
Would you do those routinely as a part of this test package? No.
When I will measure them is later. If Lady's going to HRT, I will measure them to make sure we're doing enough.
Yeah.
But at the outset,
as a measurement of the outcome of the treatment as opposed to diagnosis.
Correct.
Okay.
And I'm not going to go in at the beginning and say, if they were normal, I'm not going to say, well, you shouldn't have HRT. And if they're abnormal, I'll go, oh, well, that's what we thought.
Yes, yeah. It's not actually changing your management.
So why would I make you spend money on doing something?
And that was going to be my question, actually, is, you want people to be focusing on things that are going to drive a difference for them. Okay. So going back, so that's really helpful in terms of trying to quantify. You're looking at the person holistically, thyroid, weight, cholesterol, cardiovascular risk, and general health, of course, and mental health being hugely part of that. Now, when you get those tests back, tell us a little bit around the treatment pathways forward. What do you treat when? And perhaps I'll take it back a step and say, what are some of the symptoms, particularly gynecological symptoms, that may need you, an empathetic GP, to try and elicit that? Because we're not comfortable talking about some of this. So in one of our last sessions, we were talking about the FIT test for testing for bowel cancer, incredibly effective screening test, and people don't really do it because it involves poo. It involves bottoms and poo. So what is it? And so trying to break down those taboos around talking about gynae health. What is it that you try and elicit in the history, and then we'll come on to treatment?
Yeah, so the one question I ask every woman, because no one will ever tell me this without being asked,
without being prompting.
How's your vagina?
Tell me about.
Are you getting any dryness? Are you getting discomfort?
Yeah.
Tell me about, what about pelvic floor strength? Are you getting any loss of urine when you cough or sneeze, or when you're going for a run, or, what's going on down there? And most of them go, oh, no, it's okay. And I go, is it? It's okay if it's not, because this is what really commonly happens.
Yes.
And no one talks about it. And it's really important to talk about it, because what happens naturally when our estrogen levels fall, so lots of people will notice their skin gets drier, their hair texture changes, their nails are less good. They notice all of that. They're bothered by a few extra wrinkles.
And women, we're quite good at picking those things up in ourselves, because you'll put makeup on your face every day, so you're quite in tune with.
We'll moisturise our skin every day.
Yeah.
Will we think about our vaginas? No. And do people go? And yes. So, and they go, oh, well, maybe sex is a bit painful. We have to do something about this, because there is something we can do about this. But equally, if we don't do something about this, there's problems that you will probably face in the future. And this is where women have no idea, the majority of the time, about what could happen in the future if we do nothing. Because we've touched on the menopause is natural, so therefore we should endure it.
Yeah.
No, there's no prizes at the end of the day for getting to the end having suffered.
Yeah. And people do suffer.
And people do suffer, and they suffer in silence.
Yeah.
And they feel they should, because that's what our mothers probably did. So as that estrogen decreases we'll notice the vagina gets a bit dry. That's happening to all the surrounding area. That affects our bladder health as well. We get much more likely to get urine infections, UTIs.
So urinary tract infections are more likely to happen as well, which people might not put the two and two together.
Correct. And there are so many women in this world who are on low-dose antibiotic treatment for years and years and years because of repeated UTIs. They're getting
no one's asked the question.
And no one's gone, should we give you some vaginal estrogen?
Yes.
Which will, so there was a study a while ago, and they found in women with recurrent UTIs, we reduced, so UTI, I'll backtrack a little bit. When you're in your 20s and you get a UTI, it burns, you pee a lot, you may notice your urine that's cloudy, you may get some blood in your urine, you'll go to the doctor, you'll get some antibiotics, job done. That starts, generally then, we get it in our 20s, and then it kind of disappears off. And then people in their 40s and 50s start coming back and going, oh, I think I've got a UTI again. I haven't had one for years. Okay, fine. Right, so we should do something. When you're elderly, when you're in your 80s, you get a UTI, that may not be how that presents. Often the first symptom is confusion.
Yes.
Or somebody falls over.
Yeah.
There is a risk. As we get older, you can become very unwell from a UTI. You can end up in hospital. You can die from a UTI.
Yeah.
We know that vaginal estrogen reduces, in women with recurrent UTIs, reduces their risk of death by 70%.
70%?
70. And this is something super safe. Everyone worries about estrogen. I'll come on to talk more about the rest of HRT, but estrogen's only really acting in one area. Very little of it's getting to the rest of our body.
It's topical, essentially. It stays where you've put it, as it were. Yeah.
Even a lot of women who have breast cancer can still safely take vaginal estrogen. it's that safe. It can now be bought over the counter. You can go into the chemist and buy it, albeit you can get a tiny tube and it says don't use it for more than 2 weeks. But
sure, but you can get it. It's over the counter. Yeah, that's how safe it is. Yeah,
it's safe. It's readily available. And if I said to you, you might reduce your risk of dying by 70%, go.
You would absolutely do it.
Obviously, please speak to your doctor. And if there's if you've had breast cancer, absolutely. But
have that assessed. Yeah, amazing. That. Okay, so I
asked everyone about their vagina. So that's why I tell them all of that in great detail.
Talk about your vagina. So vaginal dryness, recurrent UTIs.
So they'll start finding sex becomes a bit painful. They'll they notice their libido is
not quite what it was, maybe.
I'll ask them about that because often that's causing a problem in their marriage, and they won't talk about that because that's embarrassing to talk about.
Yeah.
But actually, that's causing another source of stress for them and more sleepless nights and.
And probably they haven't talked to anyone about it. Yeah. They might welcome the opportunity of a sympathetic and empathetic ear from someone who goes, actually, we can help.
Well, and actually just know it's normal.
Yeah, yes,
because their friends don't talk about it.
No.
Their friends might talk about the hot flushes.
Yes.
Friends might talk about some of the more, I don't know, safe.
Yes, socially less.
Socially acceptable. They're not going to sit over a glass of wine with their friends talking about their vagina and how dry it feels.
Going back to suffering in silence. Yeah. So those will be the sort of the very varied and to some degree not always easy to define symptoms of menopause or perimenopause. And so we've talked about that and what tests you would do, looking at the whole patient, looking at the whole person very holistically. And at what point do you start to think, we'll initiate treatment, and what is that treatment options open to you? Yeah.
So big myth is often women think that things aren't bad enough yet to start treatment.
Okay.
I mean, I don't get that. But again, when we get to the end of this life, no one's going to give us an award for going, well done.
You've suffered.
You suffered for another 5 years more than you needed to.
Yeah. No. Again, don't suffer in silence. We're going to come back to that.
Don't suffer in silence.
Yeah.
So there's that one myth is, oh gosh, is it too early? Are things not bad enough yet? Do I really need them? Sorry, yes. You are allowed this. Your body has stopped making the same hormone you've had for most of your life.
Which has its protective effect on you as a woman.
Hugely protective effect. So yes, have it. So what we want to do, the main thing for symptom control is we want to replace the estrogen that they're losing. And so we give them that. If you were to just give a woman who still has a womb, i.e. who hasn't had a hysterectomy, who just gave a woman estrogen, that womb lining we talked about earlier gets thicker and thicker and thicker.
Because that's what estrogen does.
Because that's what estrogen does. And we need progesterone to keep that lining nice and thin. Because if we didn't do that, there's a risk that thick lining could turn it. There could be some cancerous changes that turn to that. So we need to give progesterone to protect the lining of the womb. And we can give estrogen and progesterone in many different ways. We like to give estrogen through the skin because giving it through the skin avoids the estrogen being metabolized through the liver. And if it passes through the liver, can be a slightly higher risk of getting blood clots. So that's things like DVT, so deep vein thrombosis affecting the legs, or PE, pulmonary embolus in the lungs. So we give it through the skin to
and to be clear, when you give it through the skin, it does not have those.
It does not
have those side effects.
And even women who've had previous blood clots can safely take estrogen.
That's a really important point, isn't it?
Yeah. Because a lot of women think, oh, I could never take the pill. I mustn't be able to take HRT or know.
So to your point, the difference is if you've taken something by mouth, goes into your tummy, absorbs in your liver, acts as a filter, doesn't it? And it breaks things down, and it is the side product of that breakdown, metabolism would be the jargon term, that then results in a higher increased risk of potentially forming a clot. Yeah.
Now, it doesn't mean that oral HRT, oral estrogen, isn't safe. And for many women, it's a great option, but it's not the thing we go to first.
Because we've got a safer and really easy option to do it through the skin. Got you.
So we give it through the skin, and that can be given either as a gel, a spray, or a patch. The gels and sprays you put on every day, and the patch you do twice a week. So they're all the same estrogen. And we want to give the estrogen that's closest to what our body naturally makes, which we call body identical. And the only difference for women is, do you want to do something every day, or do you want to do something twice a week?
Whichever fits with your life better.
I can't tell you what day of the week it is. So do not give me a patch I need to change twice a week, because I have no idea.
And you will forget.
Or shall I change it? What shall I do? I don't know. So give me something I can do every day. I get in the routine, just like I put my moisturiser on my face, I put my estrogen gel on my leg.
End of story.
End of story. Job done. And then the progesterone can be given by mouth, and that's safe by mouth, and we don't have the issue with blood clots with that. And if women are still having periods, we give it to them for half the cycle at a slightly higher dose. And if they're not having, if they haven't had periods more than a year, we give them a lower dose
throughout the
every day.
cycle.
There's not really a right or wrong to it. If you were to give a lower dose every day to women still having periods, they just might get a bit more sort of unpredictable bleeding than they're used to. It's not doing any harm, so you can't get it wrong.
Yes.
Because their lining of their womb is still a little bit what we would call unstable.
Sure.
After they
have to
stop
be a
their
little
periods,
bit more responsive to the estrogen. Yeah.
after their periods have stopped, we know that isn't the same issue, so we give them a lower dose every day. The lovely thing with the progesterone is for a lot of people, it makes them very sleepy. So you give it to them at night,
and actually
really
helps with
their
the sleep
as well.
pattern as
so
well.
They love it.
Yeah.
They love that. You can also give the progesterone through what we call an intrauterine device. The one that we use for that is the Mirena, which is
the coil.
The coil, which a lot of women use for contraception. It's a treatment for heavy periods. It's obviously, you have to put that in. It's a slightly invasive procedure. It's not you don't need to.
And has to be done by a professional.
Has to be done by a gynecologist.
Yeah.
Or somebody that's trained in
Trained to do that. Yeah.
And it's a bit uncomfortable having one put in. Takes about 20 minutes, but that's it.
Once it's done, it's
and it's there for 5 years.
Yeah.
So happy days. Some women will already have one because they're using it for contraception or they've had a treatment heavy periods.
Easy.
Great. Carry on.
Yeah.
The difference between using it as contraception and using it for HRT is it's licensed differently in terms of how often you need to change it. So you need to change it every 5 years for HRT. It's now licensed for contraception for 8 years. So you can't use it that long if you're using it for HRT. Because we need to make sure it's protecting that womb lining enough. And you can give progesterone through a combined patch with the estrogen, but it's not it's what we call synthetic progesterone. It's not the same body identical progesterone. And therefore, it's not necessarily our first choice, but it's a very convenient choice for a lot of women. They only have to do one thing.
Okay. That's very helpful. That really does.
And then we've got the vaginal
estrogen. Tell me about the vaginal estrogen.
Which we give separately.
In addition to.
We don't necessarily start with that initially. But
because the skin, the topical one might be enough.
Maybe enough. But in some women it's not enough. So we'll review that, and things will change.
Yeah.
Our estrogen, when we start on HRT, our body's still making some estrogen, and that's getting less over time. So with time, we may go on to need that on a different dose of what we're taking systemically. Secondly, we may then need the vaginal estrogen.
Got you. Okay.
And the vaginal estrogen is something that you initially start with. You give a sort of loading dose to replenish that estrogen level for 2, 3, 4 weeks, and then you do it twice a week. And that can be given either as a cream with an applicator or a little pastry that goes inside.
Okay, very easy.
Really easy.
Okay, yeah, and works very well.
And very
fantastic. Effective. So that's wonderful. So we've covered essentially presentation, diagnosis, tests, and treatment options. Would like to go on to what happens to your body once you're either going through or have gone through the menopause in terms of particular organ systems, which is to say, for example, bone health. Let's start there. So what happens to your bones to some degree, as we all age, but what happens to your bone health in particular as a woman when you go through the menopause?
So I'll start right at the beginning. We're building up our bones are getting stronger and stronger until we're about 25. And then the density of our bones is diminishing.
From then on.
We're on the downhill from 25. But it really, that loss accelerates after menopause because estrogen is protective for bone health. So when we lose that estrogen, then that density reduces. And what that means is our bones can become weak enough that they're much more prone to breaking. And that's what we can develop something called osteoporosis. And the sort of in-between phase between normal bone density and osteoporosis is something called osteopenia.
So osteopenia being thinning
and
osteoporosis being too thin.
And we know that if we give estrogen through HRT, we are mitigating some of that loss. breaking a bone, most people are, oh, well, if I break a bone, I'll,
have it set.
Off
fine.
we go. It'll heal and I'll get better. That may be the case. But if you break a big bone, like
say
your hip, that's a big deal.
Yep.
And if it happens when you're old,
that's a really big deal.
Very big deal. And what a lot of people don't know is that 10% of people who break their hip when they're older will die within a month.
10% within a month.
And 33%, a third of people will die within that year.
So if you were to break your hip when you're over 75, then you've got 1 in 10 chance of dying within a month and 1 in 3 chance of dying within that year. So it actually is not just a broken bone.
No, it's not just a broken bone. And there's something we can do to prevent that. And that's, so it's not just taking HRT, it is also looking after ourselves. We've got to be, it's why certainly in our 40s, we really need to be thinking about strength training. We need to be thinking about making sure we're going to be looking after our diet, we're eating all the right things. We've got to, do everything. We can't,
holistic, full
can't
picture.
just give HRT, but never do any exercise and eat rubbish and sit on the sofa all day. Like, actually, it's not
that's
magic.
Not gonna work. Yeah. And a lot of the strength training, that's really come into the fore recently, hasn't it? Because we now, we knew it before as well, but I think probably increasingly appreciate that as your muscles pull against the bony insertion, the bone goes, right, I need to grow some more. I need to strengthen because the muscle's pulling. Yeah. So, and conversely, it works the other way around as well. If you're not moving enough, then the bone just thins. Thins and gets weaker.
And we will lose bone mass and muscle mass after menopause.
Yeah.
So we've got to.
You've got to actively work at it, don't you? Okay. So that's the bone health side of things. Let's come to cardiometabolic risks. So heart risk. So it's probably we're better at recognizing heart attack risks in women and cardiovascular risks, particularly. What's your view on how menopause plays into that? And to your point, looking at the whole person.
After menopause, when we lose all that estrogen, our risk, before menopause, women are at lower risk of heart attack and stroke compared to men. After menopause, it's a level playing level playing field.
And it doesn't mean that the men come down, it means that we go up.
We go up because we've lost that protective anti-inflammatory estrogen. And what we know is if women continue to do the same thing, so they eat the same, they exercise the same, they do all the same things, their cholesterol will go up and their blood pressure will go up.
Do we know by how much?
It varies. You've got to take so many, not that easy to answer, but it will. And you look at women's numbers.
Substantially.
You'll see a significant increase.
Cholesterol goes up, blood pressure goes up with menopause.
And those are two risk factors for us developing heart attack and stroke in older age. Women don't think of heart attacks and strokes as being something they're going to die from. I think if you ask loads of women, what do you think you'll die from? They'll probably all say breast cancer.
Yes, they would say cardiovascular events.
And actually, we are far more likely, we're far more likely to die of heart attack or stroke. We're 30 times more likely to die of a heart attack or stroke than we are breast cancer. And that includes women who've had a prior breast cancer diagnosis.
So this is about points of view and availability of information. If you said to a woman, you're 30 times more likely to die from a stroke or a heart attack than you are of a breast cancer, they would
go and address it. But I think we all think as women we're a bit invincible. We're like, oh, that's fine. That's not going to happen to me. That's most likely what we're going to die from. That or dementia. Those are things that are going to most likely to kill us. And so we've got to look after our heart health. So you've got to know your numbers. That's why I say, let's see what your cholesterol is. Is it going up? What are we doing? Actually, estrogen does help bring down our cholesterol. So women, if we start them on HRT, we'll often see that
coming down just in and of itself without even treating the cholesterol with statins or any other lipid lowering drug. Just in and of itself.
So that's super important. And, we've got to look after our heart health, and I think we all sort of
don't think about that so much. So on that point then, so what would you advise if there's women out there who go, this is super interesting, but and I really value the information, but I don't really get any of the symptoms that are described, and I'm carrying on. It seems like, I've ducked all perimenopause or menopausal symptoms, so I'm fine. When or how would you recommend them to go on HRT? Would you recommend they went on HRT if they are otherwise asymptomatic? And if so, when? And how?
So we've got a window. So let's use heart health as a good example.
Yeah.
We know there's a window of opportunity that we can benefit from those cardiovascular benefits of HRT that is up to 10 years after your last period. We know that starting HRT in that time,
within 10 years.
Within 10 years. And it's very hard in that sort of perimenopause period if you're having no symptoms at all. And we've already talked about how unreliable testing estrogen is. Right, well, what are we going to, I'm not going to suddenly necessarily start somebody on treatment for no symptoms, but we've talked about there are so many benefits of being on HRT that for a large number of people, that's probably the right thing to do at some point. So I would say certainly at or around the age of menopause, we've got that window up to 10 years. Now, obviously, if you start seeing, that's where you want to track all your numbers. If you start seeing your cholesterol's going up, your blood pressure's creeping up, you're going to have no symptoms from that. But actually, maybe there's a point we should intervene.
So would it be the case that if they went to see, say, you or anybody who sort of knows about this, you'd have a discussion around saying these are the pros and cons and these are the potential benefits. If you're entirely asymptomatic, why don't we measure your cholesterol, measure your blood pressure, measure all your other parameters, and then keep an eye? Or would you say to them, actually, why don't you start because there is this window for us to start, or is it more of a custom made?
I think it depends on what their views are. So I've got some women that are absolutely terrified of HRT.
And we'll come to that as to the why.
So it's got to feel sometimes. So somebody like that, they're going to benefit from obviously knowing all
of the things we've talked about. Yeah.
But also maybe when they do start to see that things are changing in their blood work or another thing, they're like, okay, maybe now is the time. And I'm never going to force somebody, oh God, you must go on HRT. Like that would be a ridiculous thing to do. But I think it's also normalising it. And you had a hormone that you no longer have.
Yes.
Your body's designed to work with that hormone.
And it works best when you did have that.
Best with that hormone. And if your thyroid gland stopped working and you had underactive thyroid, would you say to me, no, I don't fancy taking thyroxine, thank you very much. I'm just going to see if I can think my way out of it. No, you wouldn't. You'd take it. Yeah. So I think it's a sort of time, and what feels right for the patient. I think most people, by the time they come and see me, they're seeing, because they want to have that discussion.
They want to have that. They're open to that discussion.
Yeah, they're open to it.
Yeah.
There are times when it doesn't feel right, and actually something will then down the line something will happen. Maybe their mother fell over and broke her hip in the meeting. Something will, like
actually maybe
what? And the other thing, talking of, I just go back slightly, we don't know that our bones are getting thinner. We don't get symptoms from that either. So I will, certainly out of 50, sometimes earlier, get women to all do a baseline bone density scan so we can see what's going on there.
You do that routinely, do you, for them?
Yeah.
That's a really good idea.
Because otherwise, we don't want the first thing we know about your
bone health is a broken hip.
You break your hip.
Yeah.
Like, that's a total fail.
Yeah.
If we know about it, we can do stuff about it. We don't know about it.
Could you ask an NHS GP to do that?
Sadly, only very few people will be eligible for that.
Okay.
So the NHS has got quite strict criteria about who they can do bone density scans for, and they tend to be people that have been on high doses of steroid treatment for a while, people who've had multiple fractures, certain health conditions.
So either predisposing symptoms, okay. So it'd be very tricky to do that.
They don't offer it as a sort of screening tool.
As a screening tool,
yeah.
Okay. So that's a very interesting thing. We had a discussion about screening and what is and isn't available and how good a predictor it is. Okay. So now let's go on to the topic that I think a lot of people are interested in, which is the risks associated with HRT. What are the real risks associated with HRT, and what are the perceived risks which may not be well-founded?
Yeah. So, as I said, a lot of women are frightened about HRT, and this stems back to a large study in the early 2000s, the Women's Health Initiative, which was the biggest study we had at that
time.
And they were doing that study to try and show how great HRT was going to be for our heart health. They stopped the study because they found high numbers of breast cancer. So the conclusion was HRT causes breast cancer. And at that time, women in their droves were being taken off their HRT and being forced to feel terrible.
Getting back all the symptoms we've talked about.
Exactly. So if we think back, that's just over 25 years ago, that's when our mothers were going through menopause and everyone was stopping their HRT. So we've grown up, this current generation, thinking that HRT is terrible. This study there were a lot of flaws in the study. There were a lot of flaws in the reporting of the study. And actually, there were things that have got sadly buried. Like there was a 30% reduction in colon cancer in women taking HRT.
Yeah.
And if I went to you and said, I've got something I can give you that will reduce your risk of colon cancer by 30%, you'd probably be biting my arm for it.
Yeah, absolutely.
And so
that's a very little known statistic out of that study. 30% less risk
and actually
of colon
what they
cancer.
found in the East, there was two groups. There was an estrogen only group, and there was a woman who'd obviously had a hysterectomy, didn't have their womb anymore, and they could only take estrogen. Their risk of breast cancer was lower than the normal population.
So it's a very mixed picture.
And they basically said, "Oh, estrogen gives you breast cancer." Well, hang on, no, that's not right.
Right, because that group was better. Yeah.
So that's where
there's
all
some flaws in the reporting and the take-home messaging.
It was terribly reported, and it was in the way they use relative risk compared to absolute risk. They're like, this is, you've got a 25% increased risk of this, and you're like, oh, actually, the numbers are really tiny.
Yes.
So you've got to take it in context.
Yes.
So there is a lovely infographic I use all the time with my patients, which was created by the Women's Health Concern, which puts into nice, easy to see form, like your risk of breast cancer. So that look is looking at women in their 50s and their risk of breast cancer. So their risk of breast cancer in a normal population, women who aren't taking HRT, we're seeing about 23 cases per 1,000 women over a 5-year period. If we add HRT into the mix, so I'm talking about estrogen and progesterone, which is what the majority of women are taking, that risk goes from 23 per 1,000 to 27 per 1,000. So we're seeing an extra four cases per 1,000 women.
Yeah, which is a very small number.
Increased risk. That's the same risk as being on the combined birth control pill.
Which people take, understandably, with no second thought.
It's a slightly lower risk than women who are drinking 2 or more units of alcohol per day. Oh, surprisingly, it's slightly higher than smoking. Smoking's only an additional 3 cases, which I never think seems quite right. And what we're not talking about is if women have a BMI of more than 30 as a body mass index, so they're very overweight. That increased their risk by an additional 23.
23
so
on 23.
Risk,
So you go up from 23 to 46.
Let's talk about that. Let's not worry about poor old HRT, which is really doing very little here.
Yes.
So the risk is generally very small. If there is a family history of breast cancer, it's not. You're not going to increase that risk any further than it is. That's what it is. You've still got the slight increased risk from HRT, but it's not anything
additional.
Worse than that. And we've got to look at that risk. If you've had breast cancer, most women probably can't take HRT after that. Depends on the type of breast cancer you've had.
And that was estrogen driven.
You very much, that's a discussion to have with your
oncologist,
with your specialist. But for the majority of women, HRT is safe and a very effective treatment
for that. Excellent.
And I think people think, oh, I don't need it. You're like, well, hang on. It's preventing so many things.
Yeah.
So if you take that very small increased risk, but you go, okay, well, I've got a 30%
look at the benefits.
Reduced risk of colon cancer. I'm less likely to get osteoporosis. I'm
less likely to get
heart disease. I'm less likely to fall. I'm less likely to get recurrent UTIs. These are the things that are killing us.
And without a shadow of a doubt, there's pluses and minuses to any decision we make. So you have to sort of see it in context. So that's incredibly... It absolutely did. It really did. So do you want to touch on non-hormonal treatment options, if there are any, and what you might or might not recommend for menopause?
So there are, and I would say there are newer drugs coming onto the market. They're very much, the drugs we've got are designed to target symptoms.
Mm-hmm.
So we're not
these
getting
non-hormonal drugs.
These non-hormonal drugs. Mm-hmm. So they will be targeting hot flushes. They will be targeting mood disturbances, but they're not actually changing what's going on underneath, which is the fact that we don't have enough estrogen anymore. There are a lot of alternative therapies that people will turn to, and a lot of those contain a lot of plant-based estrogen.
Interesting.
So I would say just take that with caution. Like, we know if we're giving you HRT, we know how much we're giving you. We know it's been carefully tested. We know the exact dose. We don't know that with that, and it doesn't mean that it's necessarily as safe as what we could be prescribing you. So they are very much
use that with caution.
Yeah. And the alternatives, they're very much options for people who can't take HRT. But if you can take HRT, they're not as good as HRT. So I could talk. That would be a whole other podcast in terms of other options, but there are other options. But generally, I would say if you can take HRT,
do that.
Better.
Yeah,
but
HRT treats the underlying cause. Non-hormonal treatments or therapies essentially address the symptoms without the underlying cause being corrected.
And I view menopause as a bit of a jigsaw puzzle, and I would say there are 5 pieces in that puzzle. And we have to think about all of them. So we have to think about what we're eating. We have to think about our exercise. We have to think about our stress levels. We have to think about our sleep, and we have to think about HRT. And if we're not addressing all of those 5 things, none of
something's going to be missing. Yeah, I love that. It's very holistic, and it's looking at the whole human, because actually, if you're not eating well, if you're not sleeping well, if your diet is not good, if the exercise is not right, in and of itself, you'll feel terrible. Just put on the mix of that, that you're not making estrogen anymore, and the whole deck of cards of.
And when we feel rubbish because our symptoms are terrible, so we're going through menopause and we've got horrendous anxiety, we're not sleeping well because of our hormonal fluctuations. That's going to make our anxiety worse.
You're not going to feel like going to the gym.
You're not going to feel like going to the gym. You're going to make bad food choices.
Yes.
Because you're reaching for something that will give you
tired.
A boost. You'll give it an energy boost. Or you're feeling really down, anxious. You're going to reach for the chocolate.
Yeah.
So actually,
and that's human nature, by the way.
Yes,
we should not give ourselves a hard time for that. It's just to say, be kind to yourself. And say there is a solution there, right?
So if we actually address the hormonal part of it, we're far more likely to actually then feel a bit more energized and want to go and lift our weights and eat some better food, and
you can turn that around, can't you? I want to bring the treatment and therapy part of this and end on testosterone. That's very topical. Tell us a little bit about where that sits in this whole sort of 360 view of menopause treatment.
So testosterone is also an important hormone for women, which a lot of people don't realise. We have testosterone.
We have it. We make it.
We make it. Our levels reduce. They're not quite as dramatic as what happens to our estrogen levels, but they reduce gradually over time. And a lot of women will benefit from testosterone replacement. The guidance is we should get somebody established on the right dose of HRT and then be on that for 6 months, and then address what residual symptoms are left as to whether testosterone may benefit them.
Okay. So you don't lead with that?
So I very rarely lead with that. I would get everything else sorted first, and then we look at testosterone a little bit further down the line. The NHS have licensed the first ever testosterone product for women called Androphene.
Which is taken as a...
Again, this is through the skin. This is a cream or gel that you put on once a day. Prior to this, we were using men's products. I mean,
which is slightly crazy when you think about investment in women's health.
Well, there is, much less. Yeah. And these are products designed at men's doses. So we can't use the same amount as a man would use because we would look like men. So we have to use a lower dose, but these products aren't designed for that. So you apply this one every other day? Or my personal favourite, one of the gels, please use 1/8 of a sachet every day. I mean, come on.
What is 1/8 of a sachet?
How can you work out 1/8 of a sachet? It's ridiculous.
Are you meant to sort of squeeze it out and divide it into... what are you meant to do?
Yeah. Reality, I don't know, see, is that enough?
There or thereabouts,
There or thereabouts. So now we do actually have a product that is available and is designed at a woman's dose. And I think a lot of people are worried about testosterone, that they might grow a beard or, something they'll turn into a man. We're giving it a very low dose. Probably to a lot of women, maybe not giving quite enough, but we are. So it isn't going to cause you to grow.
It's at the dose that you need and no more.
Yes, and don't be afraid of it.
Yeah. And when would you add it in? What's the go no go decision point at 6 months after HRT where you decide, yes, we should give testosterone a try?
So it's licensed, and this is where we have a lot of it in medicine. You know, things are licensed and things are used in different ways. The licensed indication for it is women with low libido.
Okay.
It is a good treatment for libido, but libido is not just about your testosterone levels. So if women are suffering with low libido, I really want to know what's
mean
going
by
on,
that,
because
yes.
having testosterone isn't going to stop you worrying about whether your teenage son is back home from the party he was at that night.
Yes.
It's not going to make your husband more attractive. It's not going to, it's not magic.
It's not going to address the vaginal dryness that we talked about, for example.
Exactly. Some women are worried they're going to wet themselves when they have sex, so that's not going to make you want to have sex, is it?
Yes,
So we need to address all of those things.
Which goes back to the empathetic, sympathetic ear of a doctor that actually cares and really wants to listen to you in full confidence.
Exactly, and like be able to feel comfortable talking about that stuff.
Which you, by the way, probably don't discuss with anybody.
No.
All right?
No one.
Yeah.
So it's licensed for libido, but we would use it very much for people who are still struggling with low energy, just still not quite feeling themselves.
Some of that softer symptoms in some ways.
You know, we might be a bit better with estrogen, but like, I'm still not where I was.
Yes.
And it helps with that, and it helps with our strength. So it's good for bone health. It's good for, you know, it's good for a variety of things. I think we probably do really underuse it.
Is it? Okay.
And
should people ask for it?
Yeah, I think people should, but a lot of doctors aren't comfortable in prescribing it.
Okay.
So if your doctor isn't, you know, it might be worth going and see somebody who does have a special interest in menopause.
That. Yeah. Which is a perfect segue into my next question, which is if someone says, I want to get the best menopause care and advice that I can, I'm willing to pay up to a point. Where is their buck best spent in that sort of, is it to get a bone scan? Is it to see a menopause specialist? Is it to ask for a particular blood screen, appreciating that estrogen and FSH may not be the best one? What advice would you give to someone who will say, I'm willing to pay, but I really need to make this the best investment in my health, so I need to prioritize. How can I best spend that money?
I think I would, in terms of the blood tests are to make sure we're not missing anything else that's mimicking this and sort of get a bit of a baseline. Those are blood tests really that your NHS GP could do.
Yeah, going back to the cholesterol.
Go back and say, look, please can I have my cholesterol checked, my blood sugar checked, my thyroid function checked, my vitamin D, my iron. Are there reasons why I'm feeling like this that aren't?
And that's available on the NHS.
And that's available. And so you could save yourself some money by
doing that.
And we know you're probably not going to get your bone scan, so that might be something worth thinking about paying. And actually they are becoming more affordable now than they were. And I think I would say, well, go and see somebody who has got a special interest, and that can be a GP like me with a special interest in menopause, or it can be a gynecologist. Either way, make sure they have a special interest in menopause. Because a lot of people think that their gynecologist naturally will know everything about menopause.
And they won't.
And when I did my obs and gynae training, I could tell you the amount I knew about menopause. I could have written on a thick lead pencil on the back of a stamp. It was
not much.
Not well taught.
Yeah.
We were taught very little about it at medical school.
Yeah.
And if your gynecologist is mostly doing another arm of gynecology,
it's a subject in and of itself, and it needs to be given the respect and the importance it deserves. Yeah.
So don't be. I've had some people go, my gynecologist says I can't possibly be in perimenopause. I'm like, maybe
we may need to unpick that.
So just make sure whoever you're seeing, that is their interest.
Yeah. And you're clearly passionate about it.
I love it. I do talk about it a lot.
But it's wonderful because actually there's a piece around the not suffering in silence and empowerment.
Yeah.
Which leads us very nicely into what menopause at work, the sort of Equality Act, etc. What advice would you give to people? How do they approach it? Because when that first came out, there was a lot of sort of controversies, fair to say. People saying, well, look, this is a natural stage of life. It should not be, quote unquote, medicalized, with the threat of it being almost something as if it was abnormal. What are the sort of workplace rights, I suppose, that women are entitled to, or they should exercise? What's your advice there?
I think this is a really hard. So I gave a talk a while ago to a group of lawyers, and I was doing the talk with two other lawyers, and one of them said to me, she said, where I worked before, we were talking about having, our menopause policy, and there was massive opposition from all the lawyers about having one in the first place. And I thought, isn't that interesting? Because there was this assumption, people don't want it to be assumed that because they're a woman of a certain age, they are going to be suffering with brain fog and anxiety and, not being able to do their job as well. And they didn't, I thought, goodness.
So what's the perception of weakness, perhaps, do you think?
Yeah. But women shouldn't suffer, and reasonable adjustments should be made to help them with the symptoms. So, for example, like if you're working somewhere, you have to raise a uniform that's, horrendously hot and heavy, and you're getting horrendous hot flashes.
Yeah.
Adjustments should be.
And that's not unreasonable. That shouldn't be that difficult.
Totally reasonable.
Yeah.
Can women, have more flexible working? Yes, all these things should be asked for, and we shouldn't be afraid to ask for those things, because this is something that is affecting us, and I think we need to move away from this whole thing of trying
about stigmatizing a bit, isn't it? Yeah.
I have so many women say to me for years, oh, you have to give me HRT because I can't be having a hot flush in the boardroom because everyone's going to think I can't do my job if they know that I'm menopausal.
Yeah.
And I was like, oh my goodness, it's
that's
awful.
That's a very interesting thing around, some of women's psyche, behaviour, emotion being regarded perhaps as non-boardroom appropriate.
I'm not working in that woman's workplace. If it is toxic and there are men who are, whether they are or not, whether they feel that they're being judged or whatever, I can't say, gosh, go in there and demand that you must have this, because it may not be the right thing for them. But they've got, they should be able to ask for those things, and there will be, there should be policies.
Which actually is enshrined in law, sort of to try and accommodate, as best as you can.
Yeah.
And then we can finish up on, we've covered obviously presentations and treatment options fantastically well. How long should you stay on it? When should you come off?
Good question. I haven't covered that. We used to say on the back of this Women's Health Initiative study, go on the lowest dose, the shortest possible time. Definitely, no more than 5 years. Well, hang on. Sorry, our bones aren't going to stop getting thinner.
Yes.
Our hearts aren't going to stop
magically. Yeah.
So now we are very much saying this is, pretty much, you aim to be on it and stay on it. Now, every woman, we should be reviewing that each year in terms of, are you on the right dose? Because our needs will change. Are there things that we need to be thinking about that we hadn't thought about at the outset? As in like vaginal estrogen, testosterone, as in, monitoring all the things we've talked about. So they should be having an annual review. It's not just you go on this dose and you stay on that forever, but I would view it as replacing hormone, for our entire post-menopausal life, which is
keep going. Keep going.
But the other point of that review is to make sure nothing else is changing in our history. That means maybe the way we're giving it, or we need to change it, or we need to stop something. So it should always be reviewed, but I would be viewing it now much more as a lifelong
treatment therapy. Okay, amazing. Thank you. That was incredibly helpful. I learned a lot.
Thank you.
I learned a lot. That was absolutely amazing. And this is your passion. This is what you do. It's probably important to say there aren't many people like you, certainly in terms of, with a real sharp focus to this. So probably an advice to listeners to seek those who do, who are up to date with the literature, who read it, who can give you that holistic, all view of your health. Don't suffer in silence.
Yeah,
speak up.
Definitely.
Yeah.
There are no rewards for suffering. It's not worth it.
Yeah.
And we're not just putting up with something that's unpleasant. It's something that could cause serious long-term, health issues if we don't address it.
So look after yourself and be kind to yourself as well,
Totally.
I think. Yeah. Thank you so much, Laura.
Oh, pleasure.
Thank you so much for joining me. Loved having you.
Thank you.